Welcome to BOC Sciences. Today, we talk about the source and related diseases of vitamin D. It must be recognized that there is not a single vitamin D compound but that there is a family of compounds that exhibit vitamin D activity. The most important of the vitamin D compounds are vitamins D2 and D3, and the more important of these is vitamin D3 or cholecalciferol. The basis for this statement is that vitamin D3 is the vitamin produced in the skin by ultraviolet irradiation. Vitamin D2, however, is produced by ultraviolet irradiation of the plant sterol ergosterol. There are other forms of vitamin D known and their precursors. At present, the most significant of these minor forms is vitamin D4, which was synthesized as an analog of vitamin D2 by Windaus and Trautmann. This form of vitamin D is a chemical and biochemical curiosity and has been synthesized once again in recent years. Several sources of vitamin D include sun exposure, natural diet foods, fortified foods, and supplements. The best way to obtain vitamin D is sun exposure. Sun exposure enables UVB rays to reach exposed skin to produce vitamin D3. Factors that affect synthesis include the season, time of day, duration of exposure, pollution, skin pigmentation, and sunscreen use. Researchers recommend sun exposure of at least 15 to 30 minutes, twice a week. Example actions include increasing the amount of time exposed to sunlight or the type of clothing worn. Vitamin D is converted into calciferol in the liver, and then calciferol carried to the kidneys is converted into calcitriol. An active form of vitamin D, calcitriol, is then released into the blood circulation and binds to vitamin D binding protein that transports calcitriol to target organs. Vitamin D receptor is activated by calcitriol, which modulates the calcium absorption in small intestine and kidneys, phosphate loss, immune function, and leads to autophagy and an autophagic transcriptional signature in breast cancer cells. Although many of the hallmarks of rickets and osteomalacia are successfully relieved by doses of vitamin D in the range of 600 to 800 IU/day, 15 to 20 micrograms/day, recommended in the 2011 Institute of Medicine report, critics point to epidemiological data that suggest that the current recommended dietary reference ranges, also known as DRIs, do not result in plasma 25 OD levels greater than 40 nanograms per milliliter, which correlate with maximal bone mineral density or the other health benefits of vitamin D. Consequently, there has been much recent debate over the optimal level of vitamin D intakes, and this has led to a view among some experts that vitamin D intakes might need to be increased above 1,500 IU/day and possibly higher in order to achieve target plasma 25 OD levels greater than 40 nanograms per milliliter. However, the IM questions the scientific basis for these claims and points to the fact that recommendations for general populations should be based on current evidence and not opinions. As a consequence, it's not surprising that vitamin D and vitamin D analogs have been tried in attempts to slow down bone loss and reduce fracture rates in elderly patients with osteopenia and osteoporosis. Small doses of vitamin D, 800, 1000 IU, have proven effective in treating vitamin D deficiency and osteopenia in elderly populations, especially in combination with supplemental calcium, by increasing bone mineral density and reducing fracture rates. However, the use and effectiveness of active vitamin D metabolites in the treatment of osteoporosis remains controversial. Clinical trials of 1-alpha-OD3, 1-alpha-OD2, and 1-alpha-25O2D3 have been undertaken in this condition. The experience seems to have been that while benefits have been observed in terms of reductions in vertebral deformities in the second and third years of longer studies, there is no evidence that vitamin D analogs offer advantages over vitamin D or calcium in the treatment of osteoporosis. The demonstration that 1-alpha-25O2D3 is an anti-proliferative prodifferentiating agent for certain cell types in vivo, and many cell lines in vitro suggested that vitamin D analogs might offer some relief in the treatment of hyperproliferative disorders such as psoriasis and cancer. Early psoriasis trials with systemic 1-alpha, 2502D3 were moderately successful but plagued with hypercalcemic side effects. The connection of vitamin D with cardiovascular disease does not end with its role in hypertension. Work with various uremic rodent models in which there is secondary hyperparathyroidism and accelerated vascular calcification suggests that there are protective effects of calcitriol, and or 25-OD, on the health of the vascular system by suppression of the inflammatory process involved in the development of atherosclerosis, by anti-proliferative effects on myocardial cell hypertrophy, and by direct suppressive effects on vascular epithelial cell gene expression of calcification genes, for example, osteocalcin, RUNX2, and osterix. Thus, the emerging concept is that, rather than accelerating renal failure, vitamin D analogues when used at clinically relevant doses are protective to the vasculature and not deleterious, as once believed. Vitamin D mostly refers to vitamin D2 and vitamin D3, and following is the categories of vitamin D as well as some impurities. If you need related products or services, please don't forget to contact us.